Hello, I am Professor Thor Halfdanarson, and I am a consultant in medical oncology at Mayo Clinic in Rochester, Minnesota. So today I am delighted to be joined by Professor Rocio Garcia-Carbonero, the head of the GI and the neuroendocrine tumor unit at the medical oncology department at the University Hospital, 12th of October in Madrid, Spain, and also to be joined by Professor Nicola Fazio, who is the director of the Division of Gastrointestinal Medical Oncology and the Neuroendocrine Tumors at the European Institute of Oncology in Milan, Italy. Together, we will discuss the optimal management of gastroenteropancreatic neuroendocrine tumors, or GEP-NETs, with focus on peptide receptor radionuclide therapy, or PRRT. In this first video, we will cover the current state of the art in patient treatment and management. So let's start with an overview of GEP-NETs and their treatment. So GEP-NETs are broadly classified in the poorly differentiated neuroendocrine carcinomas, or NECs, and the well-differentiated neuroendocrine tumors, or NETs. So there are guidelines now that recognize NECs and grade 3 NETs, which is very important to understand that the grade 3 neuroendocrine neoplasms contain or encompass both poorly differentiated neuroendocrine carcinomas and the well-differentiated neuroendocrine tumors. We classify the GEP-NETs and GEP-NECs based on the nuclear tumor grade, and the survival of patients with gastroenteropancreatic neuroendocrine neoplasms depends heavily on the tumor grade. In terms of the anatomic sites of origin, so that differs a little bit from one country to another, but it's, I think, fair to say that many of these do originate in the rectum, where they tend to be small polyps. And the next most common site of origin is the small intestines, pancreas, appendix, colon, and the stomach. The patients who have well-differentiated lower grade neuroendocrine tumors have a much longer overall survival than those with higher grade neuroendocrine carcinomas and those with mixed tumors. So the grade or tumor grade is a very strong predictor of survival in patients with neuroendocrine tumors, but not the only important determinant of outcomes. Stage, patient age, performance obviously play a huge role as well. So for localized grade 1 to grade 2 disease, resection is often advised, but for certain patients, surveillance is appropriate. So first-line therapy for patients with positive somatostatin receptor PET is often somatostatin analog therapy, but that depends a little bit on the tumor grade as well. And sometimes patients with metastatic disease are suitable for debulking or extensive surgery to remove as much tumor as possible. And then at any point in time, we should consider clinical trials and even local regional therapy, such as liver-directed therapy with embolization or with ablation. We have radioligand therapy, or PRRT, targeting the somatostatin receptor. And the one currently approved is lutetium-177 dotatate, but others are on the horizon. We have the multi-targeted tyrosine kinase inhibitors like cabozantinib and isotope. For some patients, chemotherapy is appropriate, especially pancreatic neuroendocrine tumors and, of course, the poorly differentiated neuroendocrine carcinomas. And then we have the mTOR inhibitors like everolimus. So let's pause and take a look at the radioligand therapy, or PRRT. So this essentially is a therapy targeting the somatostatin receptor, essentially delivering a charge or a radioactive particle in close proximity to the tumor. So it is composed or comprised of three main parts, or four main parts actually. We have the octapeptide, or the somatostatin analog, that binds to the somatostatin receptor on the tumor cell. And the other key component, obviously, is the radionuclide, in this case, lutetium-177. And then we have a chelator that sort of contains the radionuclide, and a linker that binds the chelator and the radionuclide to the somatostatin analog. So the first question is, what are the guideline recommended systemic therapies for gastroenteropancreatic neuroendocrine tumors, or GEP-NETs, and how does the treatment differ by grade and location? We'll let Professor Garcia-Carbonero go first.
So the first thing we need to know in the GI tract, is this a pancreatic tumor, or is it a small bowel, or is it or coming from other sides? And then, generally speaking, for the very indolent ones, we can start with somatostatin analogs. Generally, those are tumors with Ki-67 index below 10%, but this is not a super clear-cut thing. You need to take into consideration other factors like patient age, comorbidities, other health problems, and so on. So, and then upon progression, if we are talking about mid-GEP-NETs, then it would be radioligand therapy is generally the preferred option. We have very solid evidence there for this case. In the case of pancreatic primaries, there's more debate because we have other options, targeted therapies, we have chemotherapy, and there's more debate as to what to do first. So we have emerging evidence moving or pushing radioligands to earlier lines of treatment, but we don't have very many head-to-head comparisons. We have the bigger COMPETE trial that is comparing it with everolimus. In all these cases, radioligand therapy seems to be better in terms of PFS.
Any insights from you, Professor Fazio, on how to approach patients with advanced GEP-NETs?
Of course, we thank so much our pathologists to help us to classify GEP-NET, and they classified these tumors very well based on tumor morphology and Ki-67, but sometimes this is not enough. For example, for the high-grade GEP-NET, we could think about the well-differentiated with the high proliferation index. In such cases, of course, we need some more clinical factors to classify these tumors, and therefore these should be discussed within the multidisciplinary team of different specialists, all of them focused on GEP-NET. And after this, of course, we should consider also guidelines, we should consider recommendations, evidence, and so on.
I think in terms of choosing the optimal treatment strategy, we also need to think what are the goals of therapy. So that is going to depend also what's the tumor bulk of patients and the tumor bulk related symptoms, and also hormonal related symptoms. But if you have a lot of symptoms that you want to palliate, then probably treatments like radioligand therapy or chemotherapy, if you are talking about pancreatic NETs, then become more relevant for that particular patient. There's been major practice-changing trials in the last few years. And all these things we need to take into account. I think the ENETS guidance are quite practical.
I tend to gravitate more and more to the ENETS guidelines because they take on specific questions more than some of the other guidelines. So let's move on to the next question. So, and this is on radioligand therapy, or PRRT. So what is PRRT indicated for, and how can it be optimally positioned within the therapeutic sequence for GEP-NETs? And I'm particularly interested in this question because we have seen some recent data in higher grade tumors and in second line. Where should we put PRRT now?
Yes, well, I think the current label by EMA, at least, is for lutetium dotatate is approved for advanced, unresectable, or metastatic, progressive, well-differentiated G1 or G2 SSTR positive GEP-NETs. So it's good for all digestive NETs. But it specifies it's only for G1 or G2. But we have now this recent trial, the NET-2, showing efficacy in G3, but this is not endorsed by the current EMA level. If it's covered by the FDA label, because it just talks about SSTR positive GEP-NETs, which is probably a more, in my view, more adequate label. But we are a bit tight, so it depends on what country you work and what the reimbursement issues are. You may have more flexibility or not to use it, for example, in G3. But I think within the label, the current label is open enough in terms of treatment sequence. So it's really up to the treating physician how you position this in your treatment algorithm.
Thank you very much. So I would like to hear from you, Professor Fazio, where you see this, and maybe also ask you the question in terms of PRRT use in patients with functional neuronic tumors with active syndrome. Will that maybe change the way you apply it?
PRRT, I think, should be considered in all GEP-NET which have a low intermediate grade and high expression of somatostatin receptor gallium PET, functioning and non-functioning. But I think that we should follow a common way of thinking to arrive to establish if PRRT should be really performed or not. So I think that the first step to be defined within the MDT should be the eligibility. Who are the patients with the GEP-NET who can be considered eligible for a PRRT? They are patients who have a G1, G2 gastroenteropancreatic neuroendocrine tumor, so well-differentiated NEN, with a positive gallium PET, who are receiving somatostatin analog and are progressing. This is the approval of PRRT everywhere. So for these patients, of course, we have to start to consider the feasibility, first of all. Of course, the nuclear medicine expert can give us an opinion about the level of uptake of SSTR at gallium PET, and also the homogeneity of this uptake compared with the morphological imaging. So ideally, gallium PET should be perfectly concordant with the lesions visible at CT scan or at MRI. And this is a technical opinion. Then, of course, we should decide if there are some clinical aspects to be considered. For example, patients who could have slight renal failure or very high tumor burden in the liver or high peritoneal burden. These patients could be to some extent at risk to receive PRRTs. So the clinical discussion within the MDT remains the crucial key point.
Thank you very much. So just moving on to the next question. So how we can identify patients who are likely to benefit most from PRRT versus other therapies. And here I would like to focus on factors like high tumor burden, but also on patient factors like impaired organ function, decreased renal function, cardiac impairment, extensive hepatic metastases, and extensive bone metastases. And we'll again ask Dr. Garcia-Carbonero to give her thoughts on that.
Yeah, so I think there are really very, very critical factors that are often not endorsed by clinical trials, but more by your clinical practice. But of course, renal function is essential for two reasons. First, because radioligand therapy can have renal toxicity. But more so because radioligands are excreted through the urine. So if you don't have an appropriate renal function, then you're probably overexposed to the drug. Then, of course, certain other factors that are relevant are, when you have extensive bone disease, is true, or there are some, at least retrospective data that suggest you may get more or higher bone marrow toxicity. And also peritoneal disease is important because of the risk of edema and bowel obstruction. So if you have very extensive peritoneal disease, you need to be careful when giving radioligand therapy. I think the minimal requirement, of course, is that you have high expression of somatostatin receptors in a homogeneous way. But there are really so many factors to dig in that there's no right or wrong answer to these questions, I think.
Professor Fazio, any additional insight from your end in terms of where how we select the patients most likely to benefit and how we deal with some of the organ dysfunction?
Yes, of course, patient selection is the key for PRRT as it is for all other therapies. I agree on many comments by Rocio regarding the anatomical sites that can be to some extent challenging for PRRT, including bone, peritoneum, even liver. It doesn't mean that PRRT cannot be proposed to patients who have such involvement. Of course, it depends on the level of involvement. Of course, you should pay attention when you decide to treat a patient with a challenging situation. For example, a very high peritoneal mass. No, this can be a risk, as of course there is a risk of perforation, there is a risk of obstruction. But you have to consider also that that patient already has a similar risk, even spontaneously or even with other therapies. So you have to balance the risk benefit of each therapy, and you have to decide how to monitor this patient. For PRRT, I would say that there are some specific situations. For example, large mass, very highly uptaking at gallium PET, which infiltrate the wall of the stomach, for example, or the intestine. In that case, of course, there is a risk related to the tumor response. So if the tumor is very sensitive to PRRT and the response is very strong, that a perforation can appear. So it should be considered also for such patients. But as it is well known, patients with strong clinical syndrome who undergo PRRT should be well covered with an SSA, even intravenous SSA, and even with other drugs to cover all the aspects of the clinical syndrome in order to prevent the flare. Another challenging situation that I could have in mind is the heart carcinoid disease. Of course, these patients should be monitored with more attention compared with other patients. But told that, I have to say that, of course, this doesn't mean that PRRT can be contraindicated in absolute in almost any context. Of course, these challenging contexts should be very well discussed and evaluated within the MDT.
Thank you very much. So in this video, we'll discuss PRRT for treating GEP-NETs. What are the key considerations for interpreting the current and emerging data? So let's start by discussing the safety and efficacy of the approved PRRT agent, lutetium-177 dotatate. And it's fitting to start with NETTER-1. So as many of you know, this was a phase 3 trial of lutetium-177 dotatate with long-acting octreotide versus high-dose long-acting octreotide for patients with mid-gut, well-differentiated, SSTR positive neuroendocrine tumors progressing on octreotide long-acting. Looking at the progression-free survival curves in the publication and subsequent publications and presentations, you can see there's a clear and striking benefit in terms of the differences in activity. In terms of the secondary efficacy outcome, the overall survival, it was not statistically different between the arms, 48 months versus 36.3, but after accounting sort of for the patients who ultimately got the radioligand therapy, the overall difference between the groups is actually 17 months, which is substantial. In terms of the safety, grade 3 or more adverse events were seen in 41%, and not that different from the 33% with high-dose octreotide. So NETTER-2 was a different trial. So these were patients previously untreated with newly diagnosed gastroenteropancreatic NETs. And the primary efficacy outcome, which was progression-free survival as per central review, was much improved in the intervention or experimental arm of lutetium dotatate, 22.8 months versus 8.5 months. Again, no new safety signals, so we have to be mindful of the nephrotoxicity or renal toxicity, which we don't really see much of if we use appropriate nephroprotection with amino acids. There can be occasional hypersensitivity reactions. Rarely there can be hormonal crises triggered by the radioligand therapy. And then we got to be careful with the timing of the last SSA injection. It has to be 4 weeks or more away from the radioligand treatment. Nausea and vomiting used to be much more common prior to us switching to arginine and lysine as the nephroprotective amino acid solution. We'll start again with Professor Garcia-Carbonero. Any thoughts on the recently published data, the NETTER trials, and other trials? We'll get a little bit later, we'll get into COMPETE.
Yeah, well, I mean, the NETTER trials have been really very relevant because there are some centers, particularly in Europe, in Rotterdam, Milan, Bad Berka, and others that have been doing radioligand therapy, homebrew radioligands, for decades now. But the NETTER trials have been very relevant to be able to have this strategy properly approved by regulatory authorities and make it available to all countries, all centers. So NETTER-1 was really key. Now the NETTER-2 trial increases the quality of evidence, if particularly for certain primary sites for which we didn't have any prospective data, for example, pancreatic primaries. So all GEP-NETs included. This was very important, and also includes less pre-treated patients, and so that provides information regarding upfront therapy. So the results are really clear, clearly demonstrate in a very neat way that radioligand therapy clearly improves in a clinically relevant way, not only statistical significant way, the time to progression of these tumors versus high doses of somatostatin analogs. And now we have, of course, this Chinese randomized trial with this sort of similar lutetium dotatate. It's a non-carrier-added lutetium dotatate XTR-008 that demonstrates in a different patient population, particularly, the Chinese population, Asian patients. Also, SSTR positive G1, G2 GEP-NETs. Again, a significant improvement in PFS, even greater than what we had seen in prior studies, right? So this consolidates the efficacy across all primary sites, across all grades, I would say, and across all races and all across the West and East, global in a global way. And we need to be aware of the toxicity, bone marrow toxicity, particularly chronic toxicity that can include, myelodysplastic syndromes and acute leukemia. Around 2%. It varies from trial to trial, right? It may depend on the schedule.
So what are the latest clinical trial data with emerging PRRT for GEP-NETs? And I'd like to direct that one to Professor Fazio and maybe discuss some of the newer trials that we're seeing done.
Yes, I agree with Rocio that now we have a very good level of evidence that in the past was missing, a level based on phase 3 studies that confirmed us that PRRT can be active and effective not only in small bowel but also in other primary sites of the GEP context. That it can be active and effective in different lines quite early, like it is in the NETTER-2 trial, first line, second line, in COMPETE trial, first line, second line, but also in late lines. So this is a very good outcome for a PRRT. We should consider that the PRRT is the only one among all the approved therapies which is based on a selection factor. So all these patients treated with PRRT are selected on the basis of the somatostatin receptor. This is a strong potential advantage of PRRT compared with everolimus, sunitinib, chemotherapy, and all the other therapies. And of course, for these type of patients, PRRT should be considered upfront. But I again repeat, always in the context of the general therapeutical strategy and within the MDT.
So at this year's GEP-NETs meeting, and then just a week or two ago at ESMO, we saw presented data from COMPETE. So how does COMPETE, or does it change the way we approach patient selection for PRRT?
Well, yes, this is the first real phase 3 head-to-head comparison with a targeted agent, with a real more active agent, I'd say, everolimus in this case. And but they have shown some interest in subgroup analysis. That, of course, they are subgroup analysis, but they showed not so much difference for G1 and a greater difference for G2. There's not so much difference based on primary site, but there seems to be maybe based on grade. This has to be, of course, consolidated or validated in across trials. But the thing is that this would also support the fact of not being so aggressive with the G1 tumors to jump straight into PRRT up front, because we have other options that are less toxic, like somatostatin analogs, of course, and because it's at least apparently not so clear the superiority, at least in the subgroup analysis of the COMPETE trial, which needs to be carefully interpreted, of course. But I think we are increasing the evidence that can help us make wise decisions or to optimize our clinical decisions for our patients in the day-to-day practice. So it is true that it induces a high response rate, but in terms of PFS, it did not seem to be so different. So yeah, I mean, all these trials also ongoing, the compose, when it will compare with chemotherapy in higher grade, and now even the head-to-head versus alpha emitters, I think it's really getting very exciting, very interesting, and I think the standard of care and the therapeutic algorithm is going to be more dynamic in the coming years than we are going to be changing it from year to year depending on all these upcoming results.
That's a good segue into the alpha particle trial. So, again, at this year's ESMO, ASCO, and NANETS, we saw a lot of discussion on alpha particle radioligand therapies. Where do you see alpha particle therapy?
I think that the most potential advantage for alpha could be the higher response rate and also the fact that while we are discussing the rechallenge of lutetium, alpha showed us that it's possible to treat successfully patients who already received lutetium with the same efficacy. So these two clinical contexts that are challenging contexts, especially in low grade, and my opinion about complete data of subgroups are similar to that of Rocio, is of course what is our unmet need is to get a higher response rate in the low or very low grade. So when you have a small bowel very low grade with a big mass, you would like to get a tumor shrinkage, but you don't get it on the basis of this trial. It seems that the response rate is higher in pancreatic and in the higher grade. But and of course also for the timing of therapy, it's not so clear that an early timing in very low grade is so effective like in the higher grade. Therefore, I think that alpha to some extent can solve us at least two of these points.
Thank you very much. So how might the recent clinical data with the existing or emerging therapies impact our clinical practice? So do we, for example, the data presented at meetings this year, are these ready to be applied to clinical practice, or do we need more information, longer follow-up, more data?
I think the recent data certainly already changed our clinical practice in the sense that we base our decisions on the quality of evidence, of course, of the magnitude of effect, of the magnitude of benefit, balanced with the risks, but also on the quality of evidence we have to use the different options, right? So I think in latest ESMO guidelines, the guidelines from 2020, the radioligand therapy was clearly penalized in the pancreatic primaries to the sort of salvage therapy when you had run out of options because the quality of evidence was not good. Now with the NET2, clearly this changes this absolutely. So in the treatment algorithm, this pushes radioligand up in line, at least as one of the possible options, considering all the different things we have been discussing today. The fact also that it is one of the treatments that can induce a higher rates of tumor shrinkage, of course, could potentially move them to the neoadjuvant setting too, because at least for unresectable tumors. With the new alpha emitters, I think they are not ready. Of course, they are not approved, so we cannot use it on the standard of care. There are some emerging new toxicities that, again, we need to understand better, like the dysphagia associated with lead dotamtate. So all these factors are really very relevant for our decisions. I mean, it's really I think the COMPETE trial is going to lead to the approval of a new radioligand, lutetium edoxatate. I think it's going to be approved for this indication for G1, G2 GEP-NETs in first or second line therapy. So it will be one new kid in the block that we will need to incorporate and balance against what we already have.
Definitely exciting times ahead.
From a clinical point of view, I think that these studies, these registration studies, as Rocio said, now will have with COMPETE a new radioligand, or at least a new radiopeptide, no? Lutetium dotatate, other than lutetium dotatate. So I think that from a clinical point of view, the new insights of these therapies will come from post-registration studies that should investigate more and specifically the strong hypothesis raised from these registration trials. For example, the high grade than the G3 context, no? And these are probably, in my opinion, will come from real world studies.
Thank you very much. In this section, we will discuss personalizing care for patients with GEP-NET, what developments in PRRT are on the horizon, and what I wanted to discuss here is a few ideas on how we could refine or improve our use of radioligand therapy or PRRT for GEP-NET. So one would be personalized dosimetry to maximize the tumor dose or the dose of radioligand therapy delivered to the tumor while protecting critical organs like the kidneys. So we haven't really seen much on that yet, but several trials are ongoing. We have not yet discussed combination therapy much, so that is combining PRRT with radiosensitizing agents. So we have seen a few trials looking at PARP inhibitors. At ESMO, we saw a trial comparing or actually combining lutetium-177 dotatate with triapine to help increasing the efficacy of the radioligand therapy. And then we have touched on the next generation of the PRRT agents, especially the alpha particles, but there are also some other modifications meant to increase the uptake, such as the somatostatin antagonists and others. And then we will likely see substantial improvements in the way we apply imaging with novel tracers, improved PET scanners, fused imaging, and things of that nature. So there are a lot of ongoing trials. So it's an exciting field, as you can see there. And this slide just shows some of the trials that are ongoing, including combinations of PRRT with PARP inhibitors, combination of PRRT with SBRT or with stereotactic body radiotherapy, PRRT with chemotherapy or agents that could be classified as chemotherapy, and then PRRT with kinase inhibitors, including sunitinib, cabozantinib, and others. So lots of data to come. What are the emerging strategies for personalized treatment, including for dosimetry in patients receiving PRRT, and how should treatment response be monitored? And I suspect many in the audience will want to know, when do we apply PET imaging in monitoring? So we'll ask Professor Garcia-Carbonero to give her thoughts on that.
Yeah, so I think, well, there's a lot of trials trying to address whether dosimetry is going to improve, the safety of patients, and also exploring, I think, different treatment regimens. What's the optimal dose and what's the optimal frequency that we should administer these treatments? Do we really need to give one dose every 8 weeks to really slow growing G1 tumors, or maybe every 3 months is good enough, like the COMPETE trial explored, and they even seem to get lower incidence so far of MDS, because we have a ceiling, which is bone marrow toxicity most of the times. Really mitigating bone marrow toxicity, I think, is the key to be able to keep dosing these patients with other radioligands or with rechallenging with the same radioligand. Regarding how often we need to assess response, well, again, it depends what tumor we're talking about, because if we are talking about a G3 tumor with a Chi67 of 55%, maybe we need to assess a response every 2 doses. But if you have a G1 very slowly growing, and also you do the gammography after lutetium, where you can roughly see if there is any major issue going on, right? So I usually, for really low, slowly growing, I just do a PET scan 2 months after the 4th dose, and I think that's enough.
So first of all, I would say that dosimetry is the crucial point to be discussed, but we knew this from the beginning, as of course the dosimetry is the key to best personalize the therapy. Dosimetry can have 2 different goals. One is to make safer the PRRT, as dosimetry means the right dose to kidney, to spleen, to bone marrow. And of course, this is a way also to optimize this therapy in an extended period of time. The other goal is to make more effective the therapy, as of course this approved dose so far, that was a fixed dose, not dosimetry based dose, for some patients could be not enough, and for some patients could be even more than enough. But the problem is how to be sure that we gave the right dose, the most effective dose to the tumor lesions. This is another goal of the dosimetry. So I think that the dosimetry is the real advantage of PRRT compared with other therapies. And these subgroup analysis that are coming now, even that from COMPETE, from ANM, I saw, told us that, of course, it seems that this approved dose is safe, but of course, we could give even more. Regarding the tumor assessment, yes, I completely agree with Rocio. We are clinicians, so it's impossible to make homogeneous the tumor assessment. It depends on the characteristics of the tumor. It depends on the not only on the grade but the imaging up front. Therefore, the tumor assessment, I think that will remain personalized, and it will depend on the specific characteristics of the single tumor.
Excellent, thank you.
I think it's also important to know well the site of disease, because regarding whether you use a PET scan or a CT scan for reassessment. So I think if you have, I don't know, liver lesions or liver-limited disease, I think CT scans can really very properly assess response. Whereas if you have bone lesions that you may not see so well in CT scans, maybe you need to reassess with PET gallium. So it also, the imaging modality should be adapted to the type of sites of metastasis you have, I think.
Excellent point, especially regarding the bone metastases. So as we are coming to the end of this program, I would like to ask both faculty members here. So what do you see as the greatest unmet needs for patients with GEP-NETs, especially in terms of radioligand therapy?
I think one very important one is really to be able to develop predictive biomarkers that can really assess what patient is going to respond to what, because sometimes we have 2 patients with high SSTR expression both, and one has an incredible great response and the other one does not respond or even progresses early. So what's the difference? Sometimes we really cannot know with current knowledge why these two apparently similar patients are doing very different with the same treatment. I think this is very important, and this has to do with understanding better the mechanisms of resistance and how we can develop strategies to overcome them, these mechanisms. And I think treatment sequence, optimal treatment sequence is still uncertain. It's a bit better defined, but there's still a lot of things that we would need to clarify better in the long run.
Excellent points, and good as we sort of plan future trials. So, Professor Fazio, what are your takes on the greatest unmet needs in patients with GEP-NETs?
Specifically related to PRRT, I would say a similar thing than Rocio is, of course, we are happy to have a very good selection factor that is the somatostatin receptor functional expression. But we are not so sure that these can be considered a real predictive factor. As of course, sometimes it happened also to me, patients with similar characteristics could have a different, completely different behavior. And if we consider that some nuclear medicine experts in the past studied, investigated the possible predictive factor that the PPQ, based on the fact that even patients who had a very good expression of somatostatin receptor, the grade 4 of the Krenning scale, that is the best, so the much higher than the physiological uptake than is in the liver. Even in that case, a proportion of patients up to 1/3 did not respond to PRRT. This means that probably the SSTR expression is not a real predictive factor, but a selection factor. So this is one of the greatest unmet need, in my opinion.
Thank you very much. That was excellent. So I think this is an appropriate way to conclude this program. So as you heard, we've come a long way in our understanding of radioligand therapy for patients with NETs, but we still have a long way to go. But at least we have a lot of ideas about how to get us where we need to go. So I would like to thank our faculty members, Professor Garcia-Carbonero and Professor Fazio, for their participation in this program.
Thank you.
Thank you very much.